All right. Without further ado, I'm going to introduce our first speaker. I think I have her name right, but she can tell me if I say it wrong. It's Sandra Rumyantsev. She's a PharmD from Harris Methodist Hospital, Fort Worth, Texas. She's going to talk to us about Anacaulase use at a level 1 trauma center.
Hi, good morning, everyone. So my name is Sandra, and I'm a surgical trauma ICU pharmacist at Harris Methodist Hospital, and I'll be presenting the research that I did with my co-investigator, Dr. Ricci. He's our burn director at Harris Methodist. So my research project is on the use of anacaulase in a level 1 trauma center. For the remainder of the presentation, I'll refer to anacaulase. I'll refer to it as bromelain or enzymatic debridement as well. I may say Nexibrid as well. These are the following disclosures that we have with the Vericel Corporation. The objectives of this presentation will be to review the indications of anacaulase, briefly review the anacaulase data as compared to standard of care surgical debridement, and discuss the results of our single center retrospective chart review of burn patients who received anacaulase. So a little bit about anacaulase. So it's a bromelain-based topical enzymatic debridement agent that specifically targets necrotic tissue. It's indicated for eschar removal in patients and in adults and pediatric patients with deep partial thickness and full thickness thermal burns. The dosage, it's a 5-gram vial, and it's mixed with a 50-gram gel vehicle, and it's treated for about a 2.5% total body surface area. Contraindications include wounds contaminated with radioactive and other hazardous substances, as well as patients with known hypersensitivity to anacaulase, as well as pineapples or papaya. Papaya has a cross sensitivity associated with it. Going over some previous data, the first trial that I'd like to go over is the DETECT trial published in 2024. It was a multinational, multi-center randomized control phase 3 trial, and it looked at the clinical safety and efficacy of the bromelain. And the results of this trial showed that greater than 93% of patients had complete eschar removal with anacaulase. About 4% of the anacaulase patients required excision compared to the 72% of the standard of care group. And time to complete eschar removal was 1 day versus 3.8 days in the standard of care group. As far as the next trial, it was a systematic review and a meta-analysis also published in 2024. It looked to evaluate the safety and efficacy of bromelain-based enzymatic debridement compared to standard of care treatment in full thickness and partial thickness burns. They found that there was a significant association between bromelain debridement and shorter time to eschar removal. There was no difference in time to wound closure. There was a lower incidence of surgical excision in the bromelain group, and there was a reduction in incidence of autografts in the bromelain group as well. So moving on to the study that we conducted at our institution. So the purpose was to compare the outcomes of the use of anacaulase to standard of care surgical debridement on patients with partial thickness and full thickness burns. It was an IRB-approved single-center retrospective study assessing the treatment of burn patients who received enzymatic debridement with anacaulase and the patients who received standard of care surgical debridement. The primary endpoint was time to eschar removal, and our secondary endpoints included number of surgical excisions, number of transfusions needed, time in the operating room, hospital length of stay, and total hospital costs. We had 10 patients in each group, 10 patients in the Nexibrid group and 10 patients in the standard of care group. They were all about an average of 44 years old, and we had a good amount of 70% male in each group and 30% female in each group. About 50% of the patients in the standard of care group had full thickness and partial thickness burns, while 80% of patients in the anacaulase group were partial thickness and 20% were full thickness. Total body surface area was roughly around the same, 575 in the Nexobrid group and 6 in the standard of care group. As far as the etiology of burn injury, a majority of patients in the Anacaulase group had flame burns, whereas about 4 had flame in the standard of care and 4 in the scald burns. For our primary outcome, so time to eschar removal, it was about 1.7 days in the Anacaulase group, and it was about 3.4 days in the standard of care group. This was a statistically significant finding. For our secondary outcomes, the number of surgical excisions was also significantly lower in the Anacaulase group, and so was the hospital length of stay. It was significantly shorter in the Anacaulase group. Although there were lower total hospital costs in the Anacaulase group, total lower blood transfusions and total OR time and total OR cost, these were not statistically significant findings. So in summary, in our institutions thus far, patients treated with Anacaulase were associated with shorter time to eschar removal, less average number of surgical excisions, and hospital length of stay. Although we did see shorter time in the operating room, smaller operating room costs, and overall reduction in total hospital costs associated with Anacaulase, it did not show statistical significance. Although Anacaulase had positive treatment results, more studies with adequate power are needed to establish causation and applicability to future clinical practice. Because our burn program is expanding and our resources are still being developed, the use of Anacaulase has played a significant role in optimizing the operative care of burn patients by reducing the need for surgical burn excision and skin grafting. To our knowledge, this is the first study to assess the health economics of Anacaulase in the United States. Some limitations of this study, due to its retrospective nature, and obviously it was a very small study population, this is a clear limitation. Another limitation is that total hospital costs for this study relied on coordinating with the hospital finance analysis department. Currently, Anacaulase is given only in the intensive care unit at our institution, so obviously that inflates the cost of the Nexobrid group. More data is needed for various burn patient populations to develop consensus burn treatment algorithms for Anacaulase use. And we did want to note that we did have one Anacaulase patient that developed cellulitis outpatient and was readmitted in less than 30 days of discharge. So I wanted to show you guys some pictures. So this is a deep second-degree thermal burn. This was actually our first Nexobrid patient. This is before. And then this is the application of the Anacaulase. And then this is the burn wound after the eschar removal and post the soak. Okay, so what are some things that we learned? So applying it to our institution. So Anacaulase may not work well when used in contact burns based on our one case. Thermal, grease, and scald burns seem to be the best treated with Anacaulase. Hands and feet seem to be the most ideal treated locations for Anacaulase treatment. Patients may need additional fluids due to the inflammatory response of the Anacaulase. The use of silver products prior to Anacaulase application can reduce its efficacy. And application technique is important for this enzymatic debridement to have adequate sustained contact with the wound to optimize maximum enzymatic debridement. And of course, multimodal pain regimen is important to initiate prior to application of the Nexobrid. Oops. Okay, so for next steps in our institution, we are looking to create a multimodal pain regimen order set in addition to the Nexobrid order set to maximize oral medications, minimize narcotics, and expand the use of specifically oral ketamine. And we're also looking into potential integration of anesthesia for neuroaxial pain management. Now that we have an established Anacaulase treatment protocol, we will be expanding Anacaulase application to patients on the general surgical floor, thus further hoping to reduce hospital costs overall. And then we will also be collecting additional data for adequate power to establish causation and applicability to future clinical practice. And I can take any questions if you guys have them at this time.
Looks like we have a minute for questions. Do we have the microphone box?
They're on the tables.
This is new. Carl Schulman from Miami. Great presentation. Nicely done. I have a question. So your groups really weren't comparable, right? One group had much larger percentage of full thickness burns, which obviously is going to take more time and effort and procedures. So do you have a protocol on the depth of the burn that you'll treat, or the amount, so to speak, right? Because they had similar size burns, but more full thickness burns. So are you primarily targeting this towards more of the partial thickness burns? And do you notice a difference when you use it in those two scenarios?
So we do not have a protocol for using it more so with partial thickness. It's just kind of whatever patients we were able to use. We do both full thickness and partial thickness. Because so the way that I collected the data, we've been using a lot of Nextrbrid in the last year, right? So I had to look at patients before, like a year before, to collect the standard of care group, and they just seem to be it just happened to have more full thickness burns at the time, but we don't have like a change. We are using like a very thick layer of the anacaulase per burn. I don't know if Dr. Ricci wants to add anything, but that's kind of what I...
Here, have a box.
Thank you. We didn't have a specific protocol in terms of partial thickness versus full thickness. The focus, though, was on burns that I thought would benefit most from it, which would be deep partial thickness. Now, if certain anatomic areas, like the hands and the feet, even if they're full thickness, which clearly need excision, I would use it on those areas with the goal of like sparing damage to tendons and stuff like that. But it was kind of a subjective type of thing.
Wonderful presentation. We've hit the 10:30 mark.
Oh,
So
perfect. Thank you.
thank you very much.